Good morning. My name is Nancy White. I'm the Education Chair for the San Diego County Breastfeeding Coalition, and I want to welcome you to the third in our series of 6 webinars. We hope you enjoyed Carolina Ochoa last Saturday on relactation. As you know, this is World Breastfeeding, well, it's actually World Breastfeeding Week is over. We now have National Breastfeeding Month. And all of our webinars will be on at 10 a.m. Saturdays through September 5th. You can submit questions via the Zoom question and answer function during the webinar, and we'll take a look at those, but we'll also pass on any additional questions to Lori. This is being recorded, and you will receive an evaluation form and the recorded webinar within 1 to 2 days, and your certificate of attendance will be emailed to you. We do have CERPs. Right now we don't have CMEs or California Board of Registered Nursing, but we're working on that. As you may be aware, World Breastfeeding Week theme for 2020 was and is support breastfeeding for a healthier planet. Neither our planet nor our human population appear to be extremely healthy these days. Recommendations from healthcare organizations have been confusing and sometimes conflicting. With the COVID-19 pandemic ongoing, we see pregnant women and perinatal healthcare professionals looking for the newest research and recommendations on birthing and breastfeeding to help protect mothers, infants, and families. I am delighted to introduce Dr. Lori Feldman-Winter, who's a longtime friend. She's professor of pediatrics at Cooper Medical School of Rowan University and a member of the Division of Adolescent Medicine, Department of Pediatrics at the Children's Regional Hospital at Cooper University Healthcare in Camden, New Jersey. She's a graduate of Albert Einstein College of Medicine and completed her internship and residency in pediatrics at the Children's Hospital of Philadelphia. She is the current chair of the American Academy of Pediatrics section on breastfeeding and was just reelected. She's the AAP representative to the United States Breastfeeding Committee, and she's a board member of the Academy of Breastfeeding Medicine. She's co-chair of the MCHB-funded NICHPU National Action Partnership for the Promotion of Safe Sleep, Improvement and Innovation Network. She's also a consultant and physician lead for the Center for Health Equality Education and Research, Communities and Hospitals Advancing Maternity Practices. She has a lot on her plate, but she has agreed to give us the very latest in COVID research. Now, please note the views presented today are not that of any institution or organization, but rather represent the personal opinions of the presenter, but I guarantee you it's up to date as of last night. So welcome, Lori.
Thank you so much. All right, I'm going to just share my slides. And okay, can you hear me?
Yes.
Okay, great, wonderful. So thank you so much for the invitation, and I am looking forward to spending the next hour or so with all of you out on the West Coast. Greetings from the East Coast, where it's a little later in the day, but not raining. So, you know, in the spirit of California, we're currently dry. So that's a good thing. And I'm really looking forward to really beginning a conversation about this issue on COVID-19. Which is ever evolving, and really full disclaimer that much of what I say today may in fact not be true in 2 weeks from now. So we continue to learn, we continue to be humbled, and it's really been a very humbling journey to go back to our roots as scientists and learn about this novel virus, and particularly in the context of breastfeeding. So with that, I have no disclosures. So I thought it would be helpful today to spend some time discussing the virus. I hope we can learn again what we know about the transmission and issues of equity and disparity about the virus as well, before delving more specifically into the topic of COVID-19 and how it affects breastfeeding and lactation. So please bear with me as we go through some biology and epidemiology of the virus and then discuss what our current recommendations are for both the OB and neonatal populations. And finally, discuss specific recommendations to promote, protect, and support breastfeeding. And before beginning, I just want to, as Dr. White just did, wish everyone a happy National Breastfeeding Month. This week we conclude our celebration of Native Breastfeeding Week, Strong, Resilient, and Latched, and begin our third week with a spotlight on infant and young child feeding and emergencies or in emergencies. And I think that is very timely given today's talk. The entire month for our National Breastfeeding Month is described by the theme, Many Voices United. And so hopefully I will illustrate that as well as I work through this talk. And I would be remiss if I didn't give a shout out to one of my many mentors and really a trailblazer who's celebrating a birthday today, and that is my friend, Dr. Ruth Lawrence, who, just like Dr. White, helped to pave my way in breastfeeding medicine and really cultivate my interest in this field. So I thank you, Dr. White, and I thank you, Dr. Lawrence out there celebrating her birthday. So I'm excited to be presenting on her birthday. I also want to begin with a tribute to the late John Lewis by quoting him. And it is absolutely remarkable that he made these comments so close to the end of his remarkable life in a congressional testimony on May 7th in 2020. And what he said was, in the wake of this deadly virus, we should admit we have fallen short. Health inequality is once again costing lives on a scale that no one can ignore. In order to save lives and right this wrong, we must listen, learn, and take action. If we put ego and ideology to the side, we will find a way to fix the underlying flaws in our healthcare system that result in communities of color bearing the disproportionate burden of a global health crisis. And I wish we had the time to just sit and allow these words to ruminate and to let us reflect on all of the ways in which we need to reconcile our own country's failures in doing something to combat racism, to provide an anti-racism agenda, to move forward in addressing health inequities, and to, as in this talk, further understand all of the implications of not doing that and why, in fact, it is where we are with this virus. So let's just talk a little bit about the virus, SARS-CoV-2. Where did it come from? Was it made in a laboratory? We don't think so. The SARS-CoV-2 virus is one of many coronaviruses, which cause the common cold. We get common colds all the time. So they're really nothing new to humans. In fact, humans are the preferred host, humans as well as other mammals, especially bats. And there's every once in a while a mutation that leads to a bad actor. And we've known a few other bad actors of coronaviruses, one of which was the SARS epidemic about a decade ago, followed by the MERS epidemic in Europe, both of which has led to significant understanding about the SARS-CoV-2 virus. So it kind of gave us a little bit of a jump start in terms of what we're currently engaged in, which is vaccine development and technology. We think that the first strain was basically a mistake mutation, just an accidental mutation that first spread in the Wuhan open meat markets and then spread to humans and then began a pandemic. So this is the genomic structure circled, or actually highlighted in this red square box here. And you can see how similar the SARS-CoV-2 virus is to the MERS-CoV and the SARS-CoV, really much of the genomic structure is the same or replicated with tiny little bits of differences that are not illustrated on this slide, but there may continuing in its evolution to be small mutations even in the spike protein, leading to little differences in the what we call epitope or antigenicity of the spike protein. So that red area of the genomic structure is the specific genomic material that codes for the spike protein. The spike protein people have heard about. That's the thing that attaches to the receptor on cells that make people sick. And that, in fact, is the protein in which much of the vaccine technology is using to develop targets for the vaccine. So I like to think of it like a circulating house, kind of like in The Wizard of Oz. The house is circulating up in the air and it has to land. And if it can't land, it stays circulating up in the air. And it can't land because the receptor is either not there or the receptor is blocked by some kind of an antibody or something else that would prevent that virus from landing onto the surface of a human cell and then ultimately getting in. So, so this genomic structure, as I said, is known. It's been elucidated and it has really contributed a lot to our understanding, although I think in some ways it's raised more questions than it's answered. One interesting aspect of this particular virus is that the genomic structure is that of a positive sense single-stranded RNA. And what that means in molecular biology is that it basically mimics messenger RNA. And that's the stuff that is the step right before making protein. So it doesn't take a whole lot of manipulation for this virus. Once it gets into the cell, it hijacks the protein making organisms like the ribosomes, and then begins right away shooting out protein to reconfigure the structure that you see before you with the spike proteins and the membrane bound proteins and all the other stuff that houses the virus. So the virus also has some genomic material that allows for quick replication, and that's some of the targets of the medications that are being used, such as remdesivir, to remove the ability of the virus to replicate quickly once it does get into the cells and begins replicating. And so, so that's hopefully helpful in just understanding some of the things that we're going to talk about in terms of viral spread and how contagious it is. So this question is a little bit of a trick question. Why are children less likely to get ill? Well, the fact is, and I'm going to show you some slides, and one of which is a study, again, that was just published yesterday, that we're learning a lot more about children and this particular virus. It is true that children are less likely to get seriously ill than adults from this virus. And we think that has to do with the place in which that virus lands, the receptor. The gene, ACE2 gene, which encodes for the ACE2 receptor, which is the receptor where this virus connects, is necessary to develop the ability for this virus to land and infect the upper and lower respiratory cells in the body. And we think that children have a lower expression of the ACE2 gene, just like children have lower expression of other genes. Little newborns have lower expression of the genes that make for bilirubin to be eradicated quickly. So, and there's probably good reason for that. Anyway, so we think that it's less possible for the virus to actually enter into the cells of children, but that doesn't necessarily mean that the virus doesn't get into children and hang around, maybe extracellularly, we're not sure. There are studies ongoing. One is the HERO study that's going to further clarify whether differences in the ACE2 gene expression in airway cells lead to differences in diseases in children that may be more or less susceptible, such as children with asthma or children with other comorbidities. And so, so those studies are ongoing, and I think will further elucidate the problem of SARS-CoV-2 and COVID illness in pediatric patients. I want to also just add to sort of my definitions of what I'm going to talk about. So SARS-CoV-2 is the virus that causes the disease COVID-19. So when people say COVID-19, that's the disease. And so I'll probably use those terms interchangeably, COVID-19 being the disease and SARS-CoV-2 meaning the virus. So in fact, in a study that was just recently published on August 6th, we now know that in fact children are getting sick, and they're getting sick at a more rapid rate than early in the US portion of the pandemic. And we don't know why that's true. It's kind of curious. And you can see the states that are darker shade of blue here are those that have much higher cumulative cases of childhood COVID-19, California being included in that. What's been found is that in a study of over 380,000 total child COVID-19 cases reported, children represented 9% of all cases. And the overall rate of childhood cases is about 500 per 100,000 in the total population. So the most alarming part of what was published, this is a collaborative ongoing research project between the Children's Hospital Association and AAP. And so they're continuing to accumulate data from all the states. And the headline news that came out from this publication is that there's been a 90% increase in child cases over the last 4 weeks. And so that's concerning. What's different? Did the virus mutate? Did, is there some other receptor, or it's hard to know if the population changed or if the virus changed, but for whatever reason, there seems to be this uptick in pediatric cases. It's important to know that children are about 19% positive among all the children that were tested. So it's not like every child that has symptoms has COVID-19. So there's a lot of other guys that work with children know that they're sick with lots of things all the time, and all those other things didn't go away, like the general coronaviruses and cold viruses are still out and about. And so children presenting with some respiratory illness, they don't all have COVID-19. The other thing that was revealed in the study that's somewhat good news is that children were a very small portion of hospitalization. So of all the hospitalizations due to COVID-19, children represent up to only about 5%. And among all the children that have COVID-19 disease, up to 9% of those children result in hospitalization. And the really good news is that among 19 states reporting in this database, there were 0 deaths. So that's a big few, really good news. So what do we really know about how this virus is spread? And a lot of this information comes from interviews that were actually conducted by Howard Blackshner from JAMA, this one of Dr. Robert Redfield, who's the head of the CDC. And again, this is from data that haven't even yet been published in peer-reviewed journals. But we know about this whole thing to stay 6 feet apart, to do what we call social or physical distancing. And the reason for that is based on droplet spread. We think that the primary way that the virus is spread person to person is through droplets. So from coughing or sneezing or having droplets come out of one's mouth or nose. But there's emerging evidence, more and more evidence, that in fact the virus can also be spread by these tiny particles that are aerosolized and hang around in the air and go well beyond a 6-foot margin. So that leads to this issue of, well, what's the likelihood or probability that I'm going to get the disease, if I'm, however, in whatever situation or social setting that I'm in. And that really leads to the principle of what we call the attack rate. So what is an attack rate? An attack rate is the number of people that get the disease divided by the number of people that are exposed to that disease. And so what I have here on this slide are the various attack rates depending on the situation that you're in. So if you're living in a household with somebody who we know has COVID-19, you're about 10 to 40% likely to get COVID positivity or COVID disease. So, while that's pretty high, it's not 100%. So, there's things that we can do to prevent contagion. We know that if you're sharing a meal with someone, obviously your mask is off, that's about 7%. If you're just casually passing somebody in a shopping mall, that's less than 1%. The overall attack rate for SARS-CoV-2 is 5%. And if you're a healthcare worker, like going into my clinic and seeing patients or going into the hospital, not being on the COVID unit, but just in the general hospital setting, the attack rate's about 3%. But that's very different if you're in a setting that's aerosolizing. So aerosolizing procedures are things such as intubation or positive pressure ventilation or nebulization. So like when we start asthma season and we have 3 or 4 nebulizers going off in our clinic all at the same time, I think the whole clinic's really going to be full of SARS-CoV-2. And that's another reason why, certainly as pediatricians, we're pretty concerned. Other sources of COVID spread that we don't know as much about is like the contact surfaces. A lot of folks are wiping down surfaces. The reason for doing that is for things that we call fomites. So things that live on surfaces and have viral spread through touching things are fomites. We don't really know what the viral load of any of these surfaces are. We do think it plays a minor role. We also have sort of known about these super spreader events. And so what are these and why is it that we see more COVID-19 infection after these super spreader type of events? Well, we think that it has to do, with maybe some of the typical type of spread with coughing and sneezing and things like that, but it may have to do with some of the aerosolization as well. So events where there's a lot of singing or shouting, also spaces with poor ventilation or a place where you've been inside a closed room in a building where the windows don't open, like my office at work. If you're there for more than 2 hours and there is some aerosolization, then that might be a super spreader type of event or location. But there's also this notion that maybe there's individuals that render themselves super spreaders. And we're getting to learn a little bit more about that as well. There may actually be individuals, let alone the setting, that are, for whatever reason, high transmitters. So how do you know you have the virus? There's a variety of ways to detect the virus. There's what people have heard about, which is PCR technology. This has been around a while. So when I was in training over 30 years ago, we used to kind of scoff at the PCR because it was so sensitive. There were so many false positives. We would almost ignore like a urine that was positive for PCR. The technology's evolved and gotten a lot better, and so we're a little more reliant upon positivity. We think we have fewer false positives and even fewer false negatives of PCR technology. What PCR does is it takes virus that might be RNA and it has to convert it to DNA, and then it replicates it. And in replicating it, it makes it more likely to try to detect it. And I think we were just replicating it too much back in the day. And now we know that if you undergo what's called the cycle threshold, meaning replicating it up to 30 times, then there was probably not that much virus there, or definitely not contagious virus there in the first place. And we can say with pretty good confidence that the attack rate is 0. And that's important. I'll come back to that point in a little bit. But, you know, if you detected the virus after one cycle, then pretty good chance that the virus is there and pretty good chance that it's actually an infected virus. You can culture the virus, although this is really technical, it's fastidious, it's dependent on the person and lab doing that, and quite costly. So most people are not culturing the virus. And then finally, there's serology. Serology is the way to detect the antibodies to the virus. Most of the antibodies that we're looking for are those against that spike protein, and it can take up to 1 to 3 weeks to make antibodies. So again, there's a lag in being able to figure that out. So these are the two images of the different technologies, as I mentioned, because SARS-CoV-2 is a single-stranded mRNA-like virus, or an RNA. I call it mRNA because it basically functions similarly. But it's an RNA virus. Again, it has to be converted first to DNA and then replicated. And it's through these cycles of replication that we can then detect the presence of the virus. So you're not really detecting virus, you're really detecting sort of the antivirus through making DNA. Serology, you have to take a blood test, and then you take that blood and run it through things like an ELISA, looking for the different antibodies that might be present. Depending on your ELISA plate, you're looking for specific antibodies. And this is really the sequence of events that happen after getting SARS-CoV-2, initially beginning with the virus and viral load that often precedes by who knows how long, but it could be as long as a week before actual symptoms begin. And then once the viral load actually declines and you're probably not even contagious anymore, that's when you begin to see antibodies being detected. The first antibodies that we make as humans when we're exposed to anything is IgM antibodies. That's just how our B cells work. Following IgM antibodies, our B cells undergo what's called isotype switching, which then leads to more robust mounting of IgG antibodies, which tend to be the more neutralizing antibodies, and they linger longer. And so that's really what we're looking for with the vaccine technology, is the development of IgG antibodies that can linger depending on the infection, really. Some IgG antibodies stay around for almost life, and others wane and aren't around for more than a year to do their job of protection. So I think the jury's still out in terms of these antibodies. Another study that was just published and again caused concern regarding pediatric patients is whether or not children can be spreaders. Are the kids the super spreaders? And in this particular study, they looked at infants less than 1 month of age up to adults over 65 years of age. They looked at 145 patients, 46 of whom were less than 5 years of age, and all had some symptoms. None of them were asymptomatic, so I think that's an important point. And what they found, and you might think by looking at this graph that the kids less than 5 were, had less virus, but in fact it's the opposite. Remember what I said earlier, that it's that cycle threshold. So a lower cycle threshold means more virus. And so the fact that that bar is actually lower down signifies the fact that, in fact, kids less than 5 tend to have more virus. Where it is, why it is more, how it can hang around, given that they tend to have fewer receptors, I think are the questions that still remain to be answered. But as I said, the science is really still evolving. Another paper that really came out pretty early in the pandemic was this one from the CDC WMMR, looking at how sick do kids get when kids do get sick from SARS-CoV-2. And this was also a cause for concern. and really came out around the time of the first iteration of the AAP guidance and sort of supported, taking a conservative approach. And that was because even though there were fewer cases that occurred in infants, babies less than 1 year of age, what was found among these infants is that many more, greater percent, were hospitalized, signified by this dark blue area. And among those that were hospitalized, a higher percent actually ended up in the ICU with respiratory illness. So I think that was part of what led to a very conservative approach in terms of doing whatever it took to prevent the acquisition of this virus in infants. And so again, I'll show you that story too has evolved. So what do we know about perinatal transmission? I would say very little. The jury's sort of still out on it. We don't think that it is transmitted to the newborn perinatally, although I will say that there have, again, been viral particles or parts of genomic structures that reveal the virus presence in the placenta. So I think we just don't know how contagious that virus is. These were some of the early studies in China, the 33 COVID positive women. None of these babies were breastfed, and there was a preemie that got sick, and so there was a concern that maybe it was spread perinatally. There was a case series from Italy, and then finally the systematic review that was more recent up through April. Again, with infants that got sick, there was one neonatal death and one intrauterine death in that systematic review, but not clear if the outcomes of the infants and the uterine death was in fact related to intrauterine or perinatal spread of the virus. So, or was it compromised to the placenta on the maternal side? It's still not clear, and I think I think this is where we're going to have a lot more studies. But early on, in the Journal of Perinatology, the schematic was published, and I think this one in particular illustrates really what we need to do as healthcare providers in terms of PPE. It really helped us identify what procedures were leading to aerosolization, what kind of PPE to don in the delivery room and the operating room. And in this guidance was this whole section on neonatal management, which I have since X'd out because we now have data that in fact has led to a change in the way in which we manage the neonates and the mothers and babies in terms of allowing them and really encouraging them to stay together. Again, obstetrical practice, when this whole thing first began in China, they delivered all the mothers by surgical cesarean deliveries, but we now know that there's no need for that, and it's certainly preferable to have a vaginal delivery over a surgical delivery for a lot of other reasons. So what do we know about SARS-CoV-2 in human milk? Again, I'm going to be a little hedgy in my remarks because we don't think, there's no evidence to date that SARS-CoV-2 is spread via human milk, which is why we recommend breastfeeding. And yet there have been 3 case reports that have, again, found some fragments of virus. We don't know if that's contagious virus, if it's whole virus, or again, if it's just a PCR detecting some viral fragments. And we don't know the situations that might beget more infectivity of human milk. For example, in a mother who has mastitis, is that a situation that might beget a higher likelihood that the virus would in fact spread at some particular time, if that was a time that the mother was in fact herself symptomatic with COVID-19. So I think the bottom line here is that we don't think that there's virus that's contagious in human milk. And so we err on the side of caution, really. And what I mean by that is that the side of caution is to promote, protect, and support breastfeeding, because we know that that is in fact, the way to produce the best health outcomes for baby and mother. So again, the AAP, in collaboration with the children's hospitals, this is the section on neonatal perinatal medicine, have instituted since the beginning of this pandemic in the US a national registry. This was data that was pulled on July 11th. It has since evolved in and of itself. But this was the data and the time point of the data that was then utilized in issuing the third interim guidance from the AAP, which recommended rooming in and direct breastfeeding. And I've highlighted some of the parts of this. They looked at 1,736 mother-infant dyads, and at that time, about half and half were separated or not separated. And again, that was because there was a real confusion between the AAP and the CDC in recommending shared decision-making versus preferring separation versus other hospitals that just logistically couldn't provide separation, or that were baby-friendly and really felt as though there wasn't enough evidence. So they had about half and half, and ultimately it didn't seem to make a difference if they were separated or not in terms of the neonatal outcomes. I think the bottom line here is that they had 0 COVID-related deaths in this very large cohort. And again, this is an ongoing cohort. Sadly, the biggest number here is direct breastfeeding, but still not what we would like to see, which would be 90% directly breastfeeding. So I think we have room for improvement. We understand that there were many challenges in establishing milk production, milk expression for mothers that were in fact separated. And so many mothers who intended to breastfeed didn't get a chance to breastfeed early in the US part of this pandemic. I think we're in a better place now, but I think that, some of the early guidance got put into hospital policies and then became dictum and really was hard to change. So I think that's for all of us to really continue to educate our peers so that we can understand that we have to be nimble and change policy as the evidence emerges, as it is emerging literally daily. There's also an ongoing study out of California, you guys are really busy, out of San Francisco called the Priority Study. And I don't have any outcomes to present, but it'll be interesting, when they too have completed their registry of mother-infant dyads with COVID. At the time of this download, they had over 1,100 enrolled in their study, and they're looking at mothers during pregnancy that were COVID positive and those that acquired COVID even after delivery, and looking at all of the maternal care practices as well as infant feeding practices as it relates to COVID positivity. And so I think these results will also be interesting. This was another study that I think contributed greatly to the revision of the AP guidance, and this was from the group at Cornell Columbia in New York. It's just amazing that at the time of surge, these guys had the wherewithal to really dig in, lean in, and collect data so that the data could be shared and we could continue to learn. This was recently published the end of July in The Lancet, looking at 1,481 deliveries. Almost all of these dyads were actually rooming in and directly breastfeeding, which I think is interesting. Again, sort of counter to some of the guidance that was out there, but they really felt strongly that this is the best way to care for the mother-baby dyads. And in fact, in the end, with good hygiene, hand washing, wearing of a mask, separation within the room, but encouraging direct breastfeeding and rooming in, the bottom line is that they saw no cases of COVID and they were able to maintain really nice high breastfeeding rates. So that's really awesome, and I think that was really helpful in guiding the policymakers to recommend rooming in and direct breastfeeding. So what about you all in California? This was as of July 25th. You had about 450,000 cases. There's probably way more than that now, just over the last month. So things are truly surging in California. Interestingly, in California, they were able to use factors such as age, gender, income, and other demographic information to create a risk category to help identify what particular areas had higher risk, to help see if those were in fact the locations where we were seeing the higher number of cases. So it's counterintuitive, but the darker areas on this map are the lowest risk. The lighter areas, so there's no pink or light pink areas, but the area that's white is the highest risk, and that's the area surrounding LA. You can see going down the coast to the San Diego County area, you're sort of in the moderate risk area, and those are indications of population illness such as asthma, diabetes, obesity, and other health factors that contribute to what they call the social factors that might lead to a higher risk of COVID positivity. And then when we hone in deeper and look at the San Diego County cases, this is as of June 12th, you can see again the darker areas are the cases by zip code. So the area right downtown San Diego, as you would well imagine, and the area close to the Mexican border are definitely the areas that have the highest cases. And for whatever reason, there's a blip in the area around La Jolla. So again, just data for discussion really doesn't answer any questions. So let's talk a little bit about equity in the time of COVID and what the problem is. We know that living and working circumstances make social distancing, or what we like to call physical distancing, we still want people to be socially connected, isolated and challenging. It is also true that many of the COVID-19 public health messages are in English, so we're not really aware of the fact that a lot of the messages are not translated and understood by many of the populations that might be most affected by the disease. Some folks just can't do home confinement depending on their work situations, and many of these comorbid conditions are just more prevalent in populations that are less likely to actually adhere to some of the recommendations to prevent COVID-19. And as Kamara Phyllis-Jones, who was the past president of APHA, well known to many, calls out the fact that racism, which is the system that uses race as a substrate to structure opportunity and assign value, and this system has many impacts, really underpins a lot of the reason why we're seeing this pandemic, particularly among those who are most vulnerable. And as cardiologist from Northwestern, Clyde Yancey says, based on the data reported by 40 states, 1 in every 1,850 Black Americans has died from COVID-19, a mortality rate that's 2.4 times higher than for whites. And another way to think about that is that if Blacks were experiencing COVID-19 at the same rate as whites, 13,000 more Blacks would be alive today. And this was downloaded about a month and a half ago. So just think about how many more lives would be saved even by today. So I think that these figures just bring us home. And this brings me to just talk about something that I think many of us haven't heard of, some of us certainly have, and that is this condition that we call allostatic load. And so Sterling and Iyer proposed this concept that stress over a lifetime creates wear and tear on the system within our bodies. And higher amounts of stress, for example, chronic stress resulting from racial discrimination, creates a higher allostatic load, and that results in symptoms of chronic diseases like high blood pressure and fatty deposits in our bloodstream, and higher risk of blood clotting, which is another associated condition of COVID-19, having a stroke and congestive heart failure, et cetera. And so what we see physiologically with allostatic load is that this whole fight or flight response increases our stress hormones, and normally without this allostatic load, that stress hormone comes back down to a baseline that is physiologic and not harmful. But with chronic stress, it never comes back down. So it continues to go up and then come back to an even higher level. And so the set point for any additional stressor is really at a higher level. So you're constantly exerting catecholamines and hormones that actually interfere with the normal functions of healthy physiology. That's not to say that having kind of a stressful event that's situational, or what's called eustressors, aren't sometimes useful. So challenging life events can sometimes make us stronger, but that's like an isolated event. We learn how to work through that and learn from it, like a workout, you know, if you're exercising or if you're engaging in a particularly difficult, challenging task at work, and then ultimately persevere. So those are kinds of stresses that are acceptable and actually can be beneficial, but really allostatic load is harmful and leads to many of the illnesses that we see, and ultimately leads to health inequities. So it's not just the way we care for individuals splayed out across our healthcare system, really in a way that does discriminate. We all have bias, and the way in which healthcare is delivered is biased and in many cases racist, but the individuals themselves bring to the table health inequities based on generation to generation of allostatic load, some of which is actually inherited through epigenetics. So it's not only the individual that has the physiologic effects of allostatic load, but it's generations to come. And so we know that the likelihood of getting sick is unfairly and unequally distributed, but also these are individuals, particularly Black individuals, that are overrepresented in 9 of the 10 lowest wage jobs and are also in high contact essential services. So it's just not possible for many individuals to just stay at home or socially isolate or to work from home or do their work via Zoom calls or WebEx. They have to actually go into the settings that might be the highest risk settings for actually contracting COVID. So I think that's an important consideration. And I think that plays out certainly in the maternal child health population, where we forget that, what we do in the hospital might be fine in the hospital, but then after families go home, they're faced with choices and situations that we have to do a better job in understanding, and really use our allies and community support persons to help. This too actually is a very recent publication. Just yesterday, we learned a little bit more about prenatal care. And you would think that people would want to be avoiding the healthcare environment because of the concern that there would be more COVID. And these authors, again, wisely actually looked at whether or not there was a higher risk or higher odds of actually contracting COVID by doing what we want, which is to access prenatal visits more. And as you can see, there was no meaningful association between the number of in-person healthcare visits and the rate of SARS-CoV-2 infection in the sample of obstetrical patients in the Boston area. And so this was in Boston at the Brigham, very active maternity care unit in the time of the Boston COVID surge. So this was in a setting where all mothers underwent universal testing for SARS-CoV-2 infection. And it's really good news, in fact, that what we want to happen, which is for mothers to access prenatal care, which is really part of step 3 of the Baby Friendly Hospital Initiative, that they can do so with confidence that that's not going to increase their risk. In the L&D setting, so we've really evolved to the point where we are in fact testing all mothers coming into L&D screening based on symptoms is not really as helpful. We have to recognize also that intercurrent fever is common. And so while we worry that it might be COVID, it's often a sign of other maternal problems, such as chorioamnionitis. And I think that, right now everything is COVID, and I think we have to remember, the other things that do and can exist. This is just data from back in April showing that, in fact, many of the mothers that were positive, 90%, were asymptomatic despite being positive for COVID. And so it's really basic practice that all moms who are coming in to deliver are in fact tested. And that's pretty much throughout our country. And we have the ability to do that and test all of these. Regarding the ability to do other stuff, at the beginning in April of this pandemic in the US, there were shortages of like everything. And you can see that by, the orange bars here, the percent of hospitals reporting shortages. So there were shortages in PPE, there were shortages in the ability to test, we didn't have enough doctors and nurses. That's gotten better over time. This study goes through June, but I would say it's not a problem that's gone away. We're still challenged with finding enough PPE, still with the timing, getting tests back. We were getting test backs pretty quickly in New Jersey when we were surging, but now that we're not surging anymore, it can take up to 10 days to 2 weeks. And by that point, it's moot. We don't even really need the test. That's already the period of quarantine. So that's a problem. Regarding breastfeeding and COVID-19, there are concerns for the mom, the diet, and the infant that I'm going to talk about. I think one of the things we have to always remember is that exclusive breastfeeding matters. Some breastfeeding benefits are more apparent for exclusive breastfeeding than for any breastfeeding. Those are things like ear infections. But other benefits rely on exclusive breastfeeding, meaning you don't see the benefit without exclusive breastfeeding. So partial breastfeeding, isn't going to give you that same health outcome. And those are things like hospitalizations for lower respiratory tract infections and severe persistent diarrhea. And some benefits are actually associated with direct breastfeeding. So all the time that we were separating mothers and babies, we were losing the health outcome related to obesity prevention and a reduction in allergy. And so we know that exclusive breastfeeding and direct breastfeeding helps to establish the normal healthy microbiome. We're now also learning about the neonatal virome that's modulated by breastfeeding. And in this study that was, again, just published in Nature, you can see that in breast-fed babies compared to formula-fed babies, there's a completely different milieu of the microbiome, the healthy bacteria with bifidobacteria, lactobacillus, and viruses, which are pretty much eradicated and modulated through breastfeeding and human milk. And so, we think there may be a role, we don't know, in terms of human milk actually modifying the gut acquisition of SARS-CoV-2 for that reason. In addition, we've now learned that there are COVID antibodies in human milk, and it's not just secretory IgA. Lo and behold, there's actually IgG and IgM antibodies that all are targeted against this receptor binding domain, which is where that spike protein binds. And so that's exciting, and I think, again, more to come in terms of learning from the antibodies in human milk and knowing whether or not they actually are neutralizing and protective. So to set the stage for exclusive breastfeeding and breast milk feeding in the COVID epidemic, I think it's important to go back to what we know works, which is the 10 steps to successful breastfeeding, partnering with those community support groups that really speak the same language, have a trusted relationship with the moms, to know what's happening after discharge, and to not do away with what we had always recommended was in-person 2 to 3 day follow-up visits in the office to check the weights. We knew from the CDC and Korea Current's original studies showing that there's synergy between the 10 steps. So the more steps in place, it's not just additive, but they actually help to complement and synergistically work together to help increase the likelihood of achieving exclusive breastfeeding. And then in our work, there we go. In our work in the Southeast in the CHAMPS project, we were able to show actually that steps such as skin-to-skin care after cesarean delivery, as well as rooming in, were actually most protective in the Black African American population. And so it may be that the 10 steps even do more for populations that are most vulnerable in settings such as in the Southeast, where they hadn't for a long time implemented the 10 steps. And now there had been no baby-friendly hospitals initially in Mississippi when we started out, and now there's 21 hospitals that are now designated, so that's exciting. So when don't we recommend skin-to-skin contact? So obviously there's maternal indications to not do skin-to-skin care if the mom's really sick and hemorrhaging, but also the newborn. So we don't recommend skin-to-skin care for HIV-infected mothers because the recommendation is to bathe first, although I searched the literature, I combed what I could find, and I couldn't find any data to actually support that recommendation. I think it was a policy and still is a policy that was done by expert consensus opinion, but I still question whether or not that in fact is really necessary. But the other things we know, that obviously for neonatal conditions such as hypotonia or babies that have a low heart rate or decreased respiratory effort, then we would take those babies immediately to the warmer for resuscitation and not do skin-to-skin. The most recent iteration of the AAP guidance was silent on skin-to-skin, although the authors actually recommend skin-to-skin care. So I'm going to take that as a recommendation to do what we know works as far as step 4 of the Baby Friendly Hospital Initiative and to encourage skin-to-skin care. They do say to recommend what I like to call appropriately timed cord clamping, although people refer to this as delayed cord clamping. And so, you know, I think that that's done during skin-to-skin, at least on the lower perineum. And so there's no reason to have to remove that baby after that period of 60 to 90 seconds. Delaying the bath, there's good evidence to delay the bath. It actually increases breastfeeding likelihood. And so the AAP guidance says to bathe the baby soon after birth. But again, I couldn't find evidence for this even in HIV literature, so I'm not sure. I mean, that's guidance, I think, based on expert opinion and caution, but I would say that there's no great evidence to show that. And there's some evidence to say that bathing the baby can actually be somewhat harmful in removing the vernix, and using soaps, you know, and detergents can actually change the microflora of the skin, which may in fact be some of the mechanism behind establishing a normal, healthy microbiome. Regarding COVID medications and lactation, we know that remdesivir is safe, although there's little data, because it's a pretty large molecule, and it was used, in fact, in infants with Ebola. It has a pretty long half-life. We think that there's no reason not to provide mothers milk if the mom is on remdesivir. Dexamethasone is sort of one of those tried and true medications, so we think that's safe. Monoclonals, if they're used in the mother, they're very large molecules, and that might become one of the mainstays of treatment for serious COVID illness. Hydroxychloroquine is kind of off the table these days, although I think that's still one of the things where the evidence is kind of shaky. I'm definitely shaking for, but you know, I'm not sure there's great evidence against either yet, so we don't know. And then azithromycin, I think there's no evidence to use that as well, but it would be compatible if it were. And so to close out, I think that I just want to end by saying that there's no reason to interfere with the normal length of stay. There's been a huge push to get these babies out of the hospital after delivery early, like 24 hours after birth. And I think there's a good reason to not do that. We know that early onset sepsis can occur as late as 40 to 45 hours of life, and you might miss that. You may miss a rising bilirubin level. You may miss the opportunity to establish lactation and to provide mom support in kind of a cocoon-like setting, before all chaos breaks out in the home setting. So I think there's good reason to monitor the baby's weight and monitor the baby's the mother and baby diet in the rooming and setting in the hospital for 48 hours after vaginal, 72 after cesarean, and then following discharge to see that mother-baby diet. Again, there's some hospitals and clinics that are having the dad bring the baby in, and we lose the opportunity to look at breastfeeding when we have the babies coming in with the dad. And so I think there's ways to do that, to have the mom come in with the baby and actually observe breastfeeding. So this was the section on breastfeeding guidance for supporting breastfeeding following hospital discharge from the birth hospital, to support continued direct breastfeeding, but to provide that follow-up after hospital discharge. Really important to monitor for weight, and as well as risk of jaundice and just suboptimal intake. So we want to see that mom actually does establish the second stage of lactogenesis. Following that, we can certainly support telelactation visits, and they can be extremely useful, both with pediatricians as well as lactation support persons, IBCLCs and CLCs, and even peer support people that may be employed by WIC. So that's okay for follow-up once we actually do physically see the baby, see the mother, do the weights. And I think it's really important to do a weight that you can count on in the office setting. This was our recent release of our guidance on infant feeding in disasters and emergencies. And one of the parts of this I think that's important to think about is relactation, if lactation is possible. So sometimes moms make the decision not to breastfeed, but then change their mind. And I think it's always important to consider that it's not a one-way street, that moms can change their mind and make the decision after the baby's born, even after going home, to then relactate. Or moms can lactate de novo, as we know, for adoptive moms. Lastly, I think it's really key that we develop a conversations approach with our families and really try to understand what matters most to the mother and family. In a study that we did through our NICHQ project, it was interesting that in interviewing over 2,000 staff members and mothers, that what the staff was saying were the main concerns about why mothers didn't reach their breastfeeding goals. They said these three things: it was the cultural norms, or lack of family or social support, lack of a role model, and because the babies were given supplements. And the mothers are saying completely different things. And so therein lies part of the problem, is that maybe we're not listening. And so how do we become better listeners? We need to provide a safe space and truly listen and really hear mothers' concerns, validate feelings. And if there's knowledge gaps, we can step up and fill that knowledge bank. And certainly dispel myths, but I think we have to acknowledge our unbias in doing that, and really make connections, use our allies. When I teach about evidence-based medicine, I think people think about that really as just the science, or maybe just the science in our experience, our clinical judgment. But what we often forget is that it's a triad. And the part that I think we don't do well enough is to appreciate the patient's values and preferences. And so with that, we have to be humble and understand that the information about COVID-19 is emerging. History and science have confirmed the rationale to support exclusive breastfeeding. And yay, I think that our policy guidance is finally in alignment to do that. So we feel good about that. But I think we also have to be careful in monitoring mothers and babies to make sure they get off to a good start, and do take a time out for shared decision-making with mothers, families, and if babies could have a voice, we would certainly want them to. I want to shout out to a study that we're doing to get the mother's voice. This is a mother's COVID study. These are the links that are in your handout. So there's more information about the mother's COVID study. This is an international study really looking at the maternal side of the experience of maternity care practices, infant feeding choices, and then what happened after the hospital and whether the babies got sick. And it's translated into numerous languages. It says just Spanish and French on here, but it's really numerous languages, some of the Asian languages as well, because it's been disseminated around the globe. So I will now open up, I think I'm only a few minutes over, and these are the infamous ducks up at the Boston Gardens. So I'll open up to questions. And Nancy, should I stop sharing my screen so I can see the chat? Or will you read me questions?
You can leave it on.
Okay.
There's a question from Terry Long. Terry, are you on? Terry, can you ask your question?
Just wondering.
Go ahead and ask your question.
Oh, no.
We can hear you.
Oh, you can hear me?
Yes.
Yeah.
Oh, I'm so sorry. Okay, so I am not sure I understood what you said about the partial breastfeeding protection, and does the baby get the afforded protection from COVID by sometimes, like evening, some women may breastfeed only in the evening or once or twice a day. Are they afforded any measure of protection?
So that's a wonderful question. Thank you for asking. We don't even know if breastfeeding leads to protection from SARS-CoV-2, meaning the acquisition of the virus or the disease COVID-19 that it causes. So that's part of what we're looking at in our COVID mother study, but also the priority study and many other studies are looking at the outcomes of neonatal or infant COVID illness as a result of the choice of infant feeding method. So I can't tell you that any breastfeeding, exclusive breastfeeding or no breastfeeding actually matters. Our presumption, our bias is that just like every other thing that we know in breastfeeding, that the intensity and the duration of breastfeeding are both associated with the best outcomes, meaning that the more exclusive the breastfeeding is and the longer it lasts, the better the outcomes. So I would say that if your mom's, it's their choice to only breastfeed at night, and it's that or nothing, I would say go for it. You could talk about other health outcomes and why it would be great if breastfeeding could happen more times throughout the day to afford the baby protection against other diseases. But regarding SARS-CoV-2 and COVID illness, I would say, support mothers where they're at. If that's what they can do and that's how they can breastfeed, then it's up to us to support that. And then if mom has questions about other health outcomes that we do have data on, certainly answer those questions.
Okay. I don't see any other questions at this point. You did such a superb job presenting everything about COVID. So I want to say a big thank you to our speaker. It was a superb presentation, answered a lot of my questions. If you have any additional questions for Lori, please send them to us at SDCBC. I'm going to share my screen here now.
I'll stop sharing.
Okay. Please send them to us at sdcbc@breastfeeding.org and we'll send them on. And please bear with us as we continue to integrate the system and provide a more seamless interaction for all of you. You will receive an email with instructions on accessing the brief evaluation, and then your certificate will be emailed to you. And we will have a link to the recording available also very soon. We hope to host you again next Saturday, when actually I'll be speaking on the diagnosis and management of neonatal hypoglycemia and updates to the Academy of Breastfeeding Medicine hypoglycemia protocol. So keep well all, and thank you, Lori. It was wonderful. Bye, everybody. Thanks so much. Bye-bye.